Okay, hello everyone and welcome to KITE Research Rounds. Dr. Steele is going to introduce our speaker today, so I hand over the mic.
Thank you, Babak. Hello everybody, welcome to our research rounds today. It's really a pleasure for me to introduce our speaker, who is Dr. Emily Plowman. Dr. Plowman is an associate professor in both the departments of speech and hearing science and neurology. And Dr. Plowman has been a co-investigator of mine for the last 5 or 6 years. She's a well-funded scientist with about more than 10 years of continuous funding from the NIH. And those of you who are working in the areas of speech or swallowing will know of Dr. Plowman's seminal work in the areas of amyotrophic lateral sclerosis, particularly around developing assessment mechanisms that are sensitive to biomarkers of dysphagia in ALS, and also her work in rehabilitation. But today I'm really excited that Dr. Plowman is going to talk to us about a new area of her research that's been developing over the past couple of years, looking at swallowing in patients after cardiothoracic surgery. So I'll hand over to Dr. Plowman in a minute. We will take questions and answers at the end of the talk. And so please type those into the Q&A box on the Zoom platform as things go, and then we will moderate those at the end. So without further ado, Dr. Emily Plowman.
Well, thank you very much, Dr. Steele, for the invitation to present today. It's a great honor. We actually have the head of our lung transplant program here is from the UHN system, and they're known to have, I believe it's the best. If it's not the best, it's like the top few, but I believe it is the best lung transplant training program in the world. So you guys have some great folks there, not only in swallowing, but also in many other areas. And as Dr. Steele mentioned, my background predominantly has been more in ALS and neurogenic patient populations, but this is some recent work that I think is pretty exciting. And so it's an honor to present this to you here today. So I did want to start out just by acknowledging that, I'm a real proponent of team science and working together. And as you can see from these funding disclosures, I am a co-investigator on a R01 grant that Dr. Steele, who just introduced me at your center, has. But this work is really, the product of many brains and many different people coming together. And specifically, this has involved speech pathology, but about 5 or 6 other different areas or disciplines to sort of pull off, pull off this work that you'll see today. So I did want to preface it with that. Excuse me. So the beginning of this story, as I mentioned, my background actually is not in sort of ICU care settings or cardiovascular surgery for that nature. And in November of 2018, I was contacted not once, but several times by both nursing and surgery. And they said that they had concerns for potential aspiration pneumonia and poor patient outcomes in the cardiac ICU setting. And they said, can you help? And my first question was, well, how do you know it's aspiration pneumonia? And they said, oh, well, that's a good question. And they started saying they just have this sort of gut feeling that there's issues going on with swallowing. They had concerns with during surgeries. They placed some very large probes called transesophageal echocardiogram, or TEE probes. They're about the size of a garden hose, and they placed those blindly, and they were concerned that perhaps that could be having some issues with patients afterwards in their recovery. So not sort of coming from a background of this setting, the first thing we wanted to do was to determine, well, what are the current practices for screening and assessing swallowing in the cardiac ICU? And I should mention that our cardiac ICU is very active. It's a 24-bed unit. And then there's a separate unit for the lung transplant program that is also extremely busy. And so that's a separate. So we conducted this in the cardiovascular ICU 24-bed unit. We published these findings, and interestingly, when we surveyed and asked nurses, did you receive formal training in administration of swallowing screens? Alarmingly, only 18% reported that they did. And by the way, we had a 70 person response rate, which was pretty good because there's about 85 nurses that work on that floor. So this is from 70 nurses. When we asked how confident are you in performing or administering swallowing screens, you can see the data here, but sort of again, alarmingly, about approximately half said that they either were not confident or only somewhat confident in administering a swallowing screen. When we asked what types of methods or how do you screen for swallowing, there was a total of 15 different methods reported by nurses working on this same unit. And they were allowed to report as many options as they were to use. And these ranged between 1 and 4 different methods. And some of these are listed here. And you'll note many of, if not all of these are, many of these are not validated. And then finally, when we said, well, what constitutes a fail or signs of dysphagia, there were 31 signs reported and a range between 1 sign, clinical sign, and 7 clinical signs per nurse. And you'll note here some of the sort of top responses. And again, some of these were quite interesting because there's not a lot of evidence behind some of these signs. And so as a researcher, I sort of thought, well, I've hit the jackpot here because this is a great opportunity for us to perhaps do some training and to improve the lay of the land, so to speak. And so we embarked on a programmatic research plan. Phase 1 I just presented was to determine what are the current practice patterns. Phase 2 would be to develop and internally validate a sensitive bedside screening tool. And finally, phase 3 would be to train nurses in an educational program and to perform standard implementation. At that time, we could then compare important health-related outcomes, such as length of hospital stay, rates of pneumonia, reintubation, and death. And so coming into this setting, some sort of barriers that we identified for optimizing clinical care or knowledge gaps that sort of drove the work that I'll present today was firstly, risk factors for who would develop dysphagia after cardiothoracic surgery remain unclear. And so prediction models and risk stratification tools are not available to provide triaged, focused care. Secondly, sensitive bedside clinical markers have not yet been identified. And this, of course, impedes accurate and timely detection of swallowing impairment, and also therefore delays important interventions that may mitigate the development of some negative sequelae. And then finally, there are no formal practice guidelines or validated screening tools for this specific patient population and setting. And I think this explains the inconsistent and highly variable practice patterns that we noted of the nurses on this floor. So the aims of the sort of broad aims that I will present today in terms of our results were first to determine what is the prevalence of dysphagia in cardiovascular surgical patients postoperatively, to identify contributing risk factors for the development of aspiration in these patients, and to finally evaluate the impact of aspiration on a set of important health-related outcomes. So this was a 11 months prospective single-site study during which adult postoperative cardiothoracic patients underwent a fiber optic endoscopic evaluation of swallowing, or FEES, which you see here, within the acute period post-extubation, so within 72 hours. This was performed at the bedside. You can see here I'm performing a FEES exam, and you get some beautiful sort of imaging data that you can see to the right there. For our validated outcomes, we did the penetration aspiration scale, which for the speech and swallowing folks on the call here, they'll know this one very well. But this is an 8-point scale that indexes the degree of airway invasion and a participant's or patient's response to that. So we had 2 independent blinded raters rate these with a 100% agreement requirement and with discrepancy meetings held if there were any discrepancies. To index swallowing efficiency, or the ability of a patient to propel material from the mouth sort of down through to the esophagus, we use the validated Yale residue ratio scale. And this is depicted here. And essentially there are two anatomical sort of zones or sites where materials during swallowing may sort of collect, and we could refer to this as residue. And so the Yale was performed both at the vallecular site, which you see images across the top panel there, as well as the piriform sinus site, which you see images at the bottom. Potential risk factors to summarize, we were interested in looking at demographic, medical history, surgical related, and finally intubation related factors across patients. And then of course we looked at both univariate and multivariate analyses to compare in folks without dysphagia and those with dysphagia, were there any factors that were independently associated with postoperative dysphagia? So I'll just refer, for anyone interested, these are two publications that have recently come out from this data that I will refer to. And we did enroll 206 patients. We had 6 drops and 200 individuals who completed this work. You can see demographic details on the left and primary surgical procedures on the right. Of importance to note, we are a big academic center. We have 4 attending cardiovascular surgeons who were sort of providing patients for this study. And many patients underwent multiple surgeries. And so what is listed here is their primary procedure. And then in the middle is the New York Heart Association score, classes 1 sort of being the lowest severity of heart failure and disease, and level 4 or class 4 being the most severe level. So let's take a look at swallowing safety profiles post-operatively. And what was really sort of shocking to us, to be honest with you, was the fact that in gray there, that's what we would consider or expect, you know, to be normal swallowing safety, a penetration aspiration scale score of a 1 or a 2. And so what was interesting was that there were only 6% of patients in this cohort who demonstrated safe swallowing. And you can sort of see here that a penetration aspiration scale score of 3 appeared to almost be sort of the resting sort of baseline that these folks went back to following surgery. And this would indicate material entering the upper portion of the airway, but not passing below the level of the true vocal folds. The items that you see here in red, aspiration, would indicate material went below the level of the vocal folds and into the trachea. So those were the raw penetration aspiration scale scores. But now I'll just present this, which probably is a little more intuitive with safety classifications. And we have illustrative examples of a safe swallow, penetration, and aspiration. And hopefully you can appreciate this material below the vocal folds, and hopefully you can see my little cursor there. And so overall, we noted that 6%, as I said, had safe swallowing. Approximately 2/3 or 65% were penetrators into the airway and above the level of the vocal folds. And then finally, 29% had material enter the airway below the level of the vocal folds. This last group is a group we're particularly concerned about. And so we also looked at aspiration response profiles. And if you or I were to ever have something go down the wrong way, we have typically a nice defensive cough response and reflex that if it's strong enough, it will expel tracheal aspirate. Only 15% of aspirators demonstrated a cough response that was effective to expel tracheal aspirate. And interestingly, 85% or the majority of patients demonstrated the inability to remove tracheal aspirate. So these folks, we would be concerned about developing pneumonia. And then finally, this group here, we refer to these folks as silent aspirators, because at the bedside, they're quite difficult without instrumental imaging techniques to catch, because they don't show the sort of obvious sort of cough defenses or reflexes to an aspiration or airway invasion during swallowing. So over half of these patients were silent aspirators. And so we sort of started putting this story together, how some of these folks could have certainly been missed because at the time, instrumental evaluation and bedside fees weren't being routinely performed. And so of note, but remember this is a research study, only 30% of patients in this study, recruited in this study, were under speech language pathology clinical services, despite the fact that there was a much higher prevalence of swallowing impairment. Moving on to swallowing efficiency profiles with the Yale residue rating scores. These are the molecular rating scores, and things in dark navy are what we consider to be impaired. But overall, as you can see by this pie chart here, 47% or almost half of these cardiothoracic patients demonstrated residue at the molecular anatomical site, whilst at the piriform sinus site, 34% of individuals demonstrated inefficient swallowing. Taken together, however, and we classified this if a patient had inefficiency at one or more anatomical sites, 52% of these patients were classified as inefficient in their swallowing. So now I'll play for you 3 video clip examples of what we would kind of refer to as different sort of levels of dysphagia, just so that you can get a sense for this. This first example is in a patient with more what we would refer to as a milder dysphagia. This is a 75, I should say, year-old white male. He was status post a 3-vessel cabbage. He was not under clinical SOP services. You'll note that he has aspiration with a weak and ineffective cough, mild residue, and as a result of his participation in this study, speech language pathology services were consulted. This next example is in a 68-year-old white male. He was post a redo aortic arch debranching and root replacement. This patient had aspiration with no cough response, moderate residue, and a left vocal fold paresis. This patient was under clinical SOP services, however, had only undergone a bedside evaluation, which underestimated the dysphagia severity. The diet was changed per the attending physician to NPO, and there was a consult for ear, nose, and throat or otolaryngology for the vocal fold paresis. And I should probably add, for those not used to looking at these images, this is the posterior pharyngeal wall, the vocal folder here, the trachea below this region. And in the front part here, it's sort of like, imagine that you're standing on the back of someone's tongue and kind of looking down, back down through the throat. So I apologize if I didn't orientate the folks that are not used to looking at these images. This last one is a severe case. This is actually just secretions. We did not give this individual anything to drink. This was a 68-year-old white male, status post a redo aortic arch debranching with TVAR. He had multiple intubations. He was silently aspirating his secretions. You'll notice that he has bilateral bruising on the laryngeal interface, and he has a true vocal fold paralysis on the left. And we put in a consult to ENT. In addition, anecdotally, we noted some motility dysfunction, and I'll sort of show you this as well. In this first patient, they have a Dobhoff tube in place for nutrition. And if you look around this area at the back here where the upper esophageal sphincter is, hopefully no one's eating lunch right now. I bet you'll see material coming back up in this little region here.
Can you feel me back there just for a second? Just breathe out of your nose for me.
Okay, another case.
Maybe another time. Oh, you had some reflux on that one. Wow. Are you on any type of reflux medication?
Mm-hmm. Well, he was after this research study, I can assure you. So although it wasn't a aim of this current study, we did, as you probably saw in those cases, note some vocal fold mobility impairment. And so we decided to actually classify this, and with our otolaryngology laryngologist, we had him blindly rate vocal fold motion impairment profiles. And these are the data here, and we published this in the Annals of Thoracic Surgery this year. But overall, 22% of these patients demonstrated a vocal fold mobility impairment, and 83% of these were left-sided. And I'll come back to the significance of that a little bit later on in this talk. But of the individuals that had a true vocal fold paralysis, 100% of these were left-sided. So I will show you an example of this here. So you're going to want to look at these are the vocal folds here. And when you're looking at these data, it's flipped. So what you're looking at on your left is right, and right is left, if that makes sense. So I'll let this play. We're doing some voicing tasks here. It doesn't look like the audio is on here, but you'll note that this chord on the side is not moving at all. And the right chord, which you see on your left, is actually doing a pretty good job of compensating and coming back in to try and meet that chord. So I'll just play that one more time. And that comes up later as well. That was an interesting finding as well. So we're having the patient here do an E sniff task, where they say the phoneme E and then they sniff it, and that's really great for looking at vocal fold quality movement. In addition, we noticed some laryngeal mucosal injury that included vocal fold granuloma, which you see in this case up here. This is a pretty common acute injury after someone has been intubated. When you're putting a circular tube in a triangular region, you can get these sort of adhesion acute injuries. We also saw a high rate of posterior cricoid hypertrophy, edema, bruising, and vocal fold hemorrhage. We believe, for example, this could be an intubation-related injury here. And then in this last image on the bottom right-hand side, the diffuse bruising, we think this could be due to the transesophageal echocardiogram, or TEE, insertions and manipulations throughout surgery, given the size of that probe, as well as the fact that they're not doing this with any sort of image guiding. Don't worry, I won't go through this particular slide. I throw this up here though, just to show you, we exhaustively looked through all of the demographic, endotracheal, and operative factors. And the univariate analysis revealed that risk factors for aspiration were a New York Heart Association score of greater than 3. So 58% of those with a 3 or 4 were aspirators, compared to only 37% with a 1 or a 2. If it constituted a reoperative procedure, meaning that it was their second heart surgery that they've ever had in their life, it didn't need to be the same surgery, but it's not their first surgery, then there was a big difference, 16% versus 64%. The TE probe I was referring to, the greater the number of TE images that was associated with aspiration. And then larger endotracheal tubes, specifically a size 8.0 or higher. So you'll note that 64% of those who had an endotracheal tube of an 8.0 or higher were aspirators, versus only 42% with a 7.5 or lower. And it's important to note that this is the third independent publication that has found this exact same cutoff point in the last year. So I think this is really interesting, and it's nice when independent labs find very similar findings. And then finally, intubation duration, which is a well-known sort of ICU-related aspiration risk, was associated with postoperative dysphagia in a dose-dependent manner, depending on dysphagia severity. So that was just the univariate analysis. When we completed the multivariable analysis, we actually found that all 5 of these factors remained independent predictors of aspiration. You can see the odds ratios and 95% confidence intervals. And on this forest plot, you'll note that anything that moves to the left of this dotted line would indicate lower risk or be preventative, whilst things moving towards the right side would indicate a higher risk. And so this is the forest plots that plots this out. And the 2 biggest sort of risk factors that had the strongest or the highest odds ratios, as you can see here, were intubation, duration, and endotracheal tube size. So larger tubes and longer or prolonged durations. Interestingly, when we statistically modeled this, If a patient had 3 or more risk factors, the odds of postoperative aspiration was 16. And if they had 4 or more risk factors, it was 22. So, you know, our goal is we have a grant that is under review, is to actually preoperatively image these patients so that we can look at the true incidence of dysphagia and then build a risk stratification or risk calculation tool that clinicians could use to triage personalized pathways. We have validated a model in ALS that sort of gave us the idea of doing this. So this is sort of like what we hope to do. And essentially in our ALS model, patients can get a score between a 0 and 6. They get 2 points if their eating assessment tool 10 screen is a score greater than 10. They get 2 points if their peak cough flow is less than 375 liters per minute. They get 1 point if they fail the 3-ounce water swallow test, and 1 point if they're older than 70 years of age. Model optimization sort of yielded that a CUT score of 3 in the simple test had a sensitivity of 100%, specificity of 64%, and the area under the curve of 0.91 indicated that for every 100 patients coming in, it would correctly classify 91 of every 100. And specifically, we derived likelihood ratios that would go with each of the PRISM scores. So this is sort of what we hope to do in this different patient setting. So remember I told you that we also looked at vocal fold mobility impairment, and this is the publication here. What was quite intriguing to me was that the independent risk factors for who would have a vocal fold paralysis were very different and distinct to aspiration risk factors. In fact, there were no overlap. And specifically, individuals who had a body mass index less than 25, meaning that they were underweight or of normal weight, were 8.8 times higher odds of having vocal fold paralysis. Individuals who underwent an aortic arch procedure had a 10.2 times higher odds of vocal fold paralysis. And race actually had a significant association, specifically Black or Hispanic, being 6.3 times higher odds. And I'll kind of come back to this at the end to sort of talk about potential mechanisms, because I think the distinct risk factors do highlight and suggest some distinct mechanisms here that are quite interesting. Oh, actually, I didn't realize it's on the next slide. So, so what we believe is from these preliminary data is that there could be distinct mechanisms of injury, specifically to the recurrent laryngeal nerve, which, as you know, supports vocal fold movement ipsilaterally. And if you recall back to your anatomy days, this is the vagus nerve, and the recurrent laryngeal nerve takes a rather tortuous course. Rather than just going straight to the larynx, it actually wraps around the aortic arch and back up, and then to innervate the left vocal fold. And so we believe with the risk factors that we found with aspiration, that there could be mechanical damage to the upper aerodigestive tract from excessive TE manipulations, as well as compression injury to the terminal branches of the recurrent laryngeal nerve, or even the superior laryngeal nerve that you see indicated there at the laryngeal site from prolonged intubations and oversized endotracheal tubes. And then conversely, we believe the fact that 100% of these cases with vocal fold paralysis were left-sided, and of the 7 cases, 6 of the 7 were arch-related surgeries. This suggests direct trauma or intraoperative mobilization traction injuries to the right recurrent laryngeal nerve at the site of the aortic arch. And then interestingly, with the lower BMI, that is a little suggestive that frailty could be coming into play here, and we want, adequately, we didn't use adequate methods to really say specifically that, but it points to that and something that we want to look at moving forward. And then racial predispositions to injury. And so interestingly enough, reading through the literature, African-American individuals have a much higher rate of recurrent laryngeal nerve bifurcations, meaning that the nerve will split off. And so this actually will predispose them to higher rates of injury if a surgeon thinks they're on the terminal branch and they're actually not. And so, that's a very interesting finding as well. So moving on to the last aim, which was looking at health-related outcomes. Pneumonia. So pneumonia, there was a significant association with postoperative aspiration and pneumonia, and specifically aspirators were 2.6 times higher, had a 2.6 times higher odds of developing pneumonia. In addition, they had a 5.7 times higher odds of being reintubated. And you see here, 5% of non-aspirators were reintubated versus 25% of aspirators. And then finally, 90-day mortality was also significantly associated with aspiration status, 1% versus 8%. And these are actually pretty low rates considering the complexity of patients we see at this site, which is great. But nonetheless, you do see here it confers a 2.8 higher odds of death at 90 days. When we also looked at some more quantitative variables, on average, aspirators waited 85 hours longer to resume oral intake. They spent 6 days longer in the intensive care unit and 104 hours longer in the hospital. And then finally, actually that should be the other way around, 104 hours longer in the ICU and 6 days longer in the hospital. And then finally, they incurred approximately $50,000 increased cost of care during their stay. Again, when we plot this out on the forest plot here, you see the associated odds ratios. We didn't meet significance differences across aspiration status for 30-day readmission or for a discharge to a facility. So this is a little bit of a busy slide, but I threw this up here because we just published this and we had a very extensive review, and I'm sure any of the academics on this call can relate to that when you get a lot, pages and pages of things you have to change. And it's actually really nice when someone suggests that you do an additional analysis and then it yields some really fabulous data that you actually would have overlooked if they hadn't have had the insight to tell you to do that. So one of the reviewers said, well, I want you now to redo this analysis across the aspiration response profile groups. And at first I was like, oh crap, I got to back to the drawing board. But when we did this, it was actually a really great thing to look at. So when we specifically compared aspirators that had an ineffective weak cough response to expel tracheal aspirate or no cough response, and we compared those to aspirators with an effective cough response, you'll note here that none of the aspirators who had an effective cough response had pneumonia, were reintubated, were succumbed to death at 90 days, or were readmitted. And for these specific items, there was a significant between groups difference across the three groups. Additionally, when you look at some of these other factors, ICU length of stay, hospital length of stay, cost of care, the folks who were able to protect their airway actually did much better, and they sort of really they equated the non-aspirators. The one thing that was interesting was that the time to oral diet was the only thing that actually it went in a direction you wouldn't have thought. And specifically, you'll note here that they waited longer. And I assume that this is because they have a cough, they are coughing at the bedside. So the nurses are alerted to the fact that these individuals have impairment, whereas these guys are not potentially picked up as quickly. But other than that one variable, you can see here that the strong effective cough was able to differentiate outcomes, and aspirators with that effective cough performed just as good as the non-aspirators, in fact, even better in some categories. So this, of course, is great pilot data for, we're hoping to do a pilot study to look at pre-operative conditioning and strength training of airway clearance mechanisms, which is something we have a lot of experience doing in our ALS patient population. So this is the publication that just came out, and this is the graphical abstract if anyone is interested, that I think fairly nicely summarizes everything I just mentioned. I have a couple more slides. So change in clinical care, of the 200 patients examined here, 74% had some form of change in clinical care. And it's always difficult to know, if we saw something, we communicated that to the attending physicians. Because we did see a lot of things that the clinicians were not aware of at the time. In terms of for comparisons later on, we may have shot ourselves in the foot, but I'm actually okay with that if it meant that it improved a patient's quality of life and their care while they're here, because I do think we have kind of an ethical, responsibility here. But you can see here just a range of different changes that occurred due to their involvement in the study. And then another thing that was interesting is this is the 3-ounce water swallow test. This is currently under review. This is my PhD student, Justine, did this study. And when we compared to, this was a validated study performed in about 3,000 inpatients, hospitalized inpatients, and it's previously been reported to have a very high sensitivity, greater than or equal to 96%. And this represented the screening test that the speech pathologists were performing on this floor. And I know at several other sites, it is the screen that they use. What was interesting was that although it's previously been noted in other patient populations to be great for detecting aspiration, it missed 37% of aspirators here. So it had a sensitivity of 63% and a specificity of 62%. And when you take into account the cost component, this confers a $1 million increase in cost of care if we miss these folks. And I prepared this slide because I'm trying to work with the surgeons to help get another speech pathology line and to get some more equipment so that they can do more of these imaging assessments. And of course, administration need to know what is the sort of return on investment. And I would posit it goes way beyond that. But I think this is a good reminder that, just because a tool is validated in one setting, it doesn't mean it will necessarily perform equivalently in a different setting that it was not, solely validated in. And since this work as well, someone sent me this, it was in the nurse's bathroom and break room, but we have implemented some preliminary changes to sort of a triage profile if patients report with specific independent risk factors that we've shown. And then the last data slide that I'll show you, we have a large lung transplant program here. I believe they've now performed the highest number of COVID lung transplants in the world. And these folks have a really high rate of dysphagia, but we were interested to know, is it pre-existing or is it more of incident cases that occurs? And so these data show here that actually there's something going on during the surgeries or during the recovery that is leading to the development of new or incident cases of dysphagia. So we have a whole nother line of work in this patient population with Dr. Thiago Machuca, who is the person I was referring to earlier, who trained at UHN and is very fond of your institution. So we're looking at that too. So to conclude, tracheal aspiration was prevalent. It was silent, and in 85% of cases, it remained in the airway. Aspiration was associated with increased length of hospital stay, increased costs, delayed return to oral diet, pneumonia, reintubation, and death. And these data necessitate the need for accurate and early detection of swallowing impairment in postoperative cardiothoracic patients. And this will help to enable timely intervention and hopefully improved outcomes. This is sort of just a summary of some things that we're sort of working on in our kind of unit and areas. And so we've been pushing to have a dedicated speech language pathologist and more a speech pathologist being able to serve the units in this area. We've been pushing for more bedside direct imaging using fees or using modified barium swallow study. And as I mentioned, we're hoping to, with some funding, hopefully, fingers crossed, work on validating both a dysphagia risk calculator so that we can sort of predict and, follow those patients more closely, as well as a sensitive bedside nursing screening tool so that we can also detect a little better. So with that, I will end there, and I would be very happy to take any questions. And just again to acknowledge the amazing team of cardiothoracic surgeons, our otolaryngologists, and then my amazing team at the Aerodigestive Research Corps. So thank you very much.
Thank you, Dr. Plowman. That's an amazing amount of new data that is really, really important. We do have a few questions that have come into the Q&A, and to remind the audience to please type your questions in there. I guess maybe I'm going to steal the opportunity to ask you our first question.
Maybe you would. You wouldn't be able to.
I know. So the data seem to be pointing to recurrent laryngeal nerve injury as a really key factor.
Mm-hmm.
And so I'm curious, whether you think you're looking at sensory, motor, or both impairment in these patients, and how would you tease that apart?
Yeah, it's a great question. So yes, we do think that we're dealing, not exclusively, but predominantly, we think we're dealing with RLN. There could be some SLN, particularly with the site of injury for aspiration risk. We think that it is both sensory and motor, given that we have seen the vocal fold paralysis, which is clearly movement and motor. However, the fact that there is this quote unquote silent aspiration is suggestive. It doesn't tell us, but it highly suggestive that the afferent limb is affected there. I didn't present these data, but we are doing, which you're familiar with, reflexive cough testing, where we'll give somebody a toxigenic agent. In this population, it's citric acid. And there are normative data that show, if you are inhaling that at some point, you should be, there's timelines of when you should elicit a cough. So that is one way that we're able to sort of probe the system. And, we're still collecting preliminary data there. But we do have some sort of exciting preliminary data that suggests that there's a relationship between blunted urge to coughs and blunted motor responses in the silent aspirators. And so that would be, I think, a really nice study to look at differences between aspirators that do have a cough response, regardless of if it's effective or not, and those that do not. We would also be interested in doing intraoperative nerve monitoring of the recurrent laryngeal nerve. They do this for thyroid surgeries, and I've actually been in with one of the surgeons it wasn't very successful. It was the first time we were trying it, but we've attempted to do that, and we're going to actually be developing a system to do that to sort of see. And so we don't think it's absolutely everything because it's so multifactorial, but we do think that it's sort of the key player and something that we really need to sort of tease apart. So yeah.
Great. So we have a couple of questions from another Emily Barrett, I think, from my lab. So Emily's curious to find out how long post-intubation or post-extubation the average time was for the 200 odd participants in that study.
Yeah, that's a good question. So I don't want to misquote the actual data. It did vary quite a bit, and I could get that to you or to her. But it definitely, so we have a fast track program. For the fast track program, they're extubated, within about 8 hours of surgery. So there was a lot of individuals that would have been sort of fast tracked. But then it went all the way out. I believe the longest was, 300 hours or something like this. So there's a huge range, but it actually makes it nice to explore that when you have that large range. The cut, the sort of critical cut score or cut point was 27 hours statistically. When we went to publish it, they said, can't you just change that to 24 hours? It's much easier for people to follow. And we were sort of like, well, we would love to, but statistically that yielded the highest sensitivity to differentiate the aspirators versus non-aspirators. And I think that falls pretty much in line with, we're not the first people to show that in the general ICU patient population. But in general, we're worried about anyone that's over a day, essentially. But yeah,
I've heard 48 hours used commonly. So this is much earlier than that as your cut point.
Yeah.
And I guess in today's post-COVID world, or not post, but COVID world, we're encountering people who are mechanically ventilated for much longer than even 300 hours. So do you think, did you see any gradation beyond 27 hours, or was it just sort of at that point you had the risk?
Yeah, no, we did. And I could, if you want, I could probably show it back up, but I had a graph that showed intubation durations, and it was dose dependent across like severe versus moderate versus mild versus sort of normal. And so there was definitely a dose dependent sort of curve that we noted there beyond, the binary classification of did they aspirate or did they not aspirate. And so you know, I think time matters and size matters, like with regards to intubations and the materials that they're using. And I have to say, this has definitely changed with some of the anesthesiologists at our setting. They're thinking a lot more about, you know, the sizes that they're utilizing as well after these data have come out.
Great. We have a question from Rebecca Afu, who's wondering if you did secretion scale rating.
Yeah, we did. Yeah, so we did the New Zealand secretion scale. I didn't present that data because, to be honest with you, we really didn't see anything statistically jump out with that. I showed a great example of a patient who had copious secretions and was silently aspirating them. But, you know, that was like one of the most severe cases of the cohort, which is why I picked it, because it's a bit of a showstopper. But in general, you know, the data weren't very, we use that for this study. We're using it also for the lung transplant study, and it may be actually more useful there. But in this group, there really was not a lot of pathology there. So, you know, you kind of hit those floor and ceiling effects. And so it just doesn't become a useful scale for this particular data set to use, because there was really not a lot of pathology there.
I am intrigued. You had those 3 examples, what you called mild, moderate, and severe. And I guess my reaction is that I think a lot of clinicians would even consider the mild case that you represented to be of huge clinical concern. You had some aspiration,
Right.
You didn't have effective clearance, I don't think. And so can you comment on the severity gradings?
Yeah, and so we didn't utilize severity gradings for the publication, because I don't think that would be a valid necessarily thing to do. That was sort of my purpose of that, was to sort of show you in the gradation of everything we had, what we felt, you know, represented mild, moderate, and severe. For the intubation duration graph, it's funny you're asking this, because I knew you would ask about operational definition, and it related to their PAS score and their Yale score. And, you know, I can send you that if you want, but like, so for that, I had a set of rules, but for the video illustrative examples, I just chose ones that I felt to reflect, you know, like the severe one was probably, if not the most severe case, I'm pretty sure it was. And, you know, I think you calibrate to what you've seen in terms of these things. And so that was our calibration. But I agree with you, you know, there would be some folks that would, you know, freak out, you know, if, and we weren't necessarily sort of freaking out, but yeah, of the ones we saw, that we felt that kind of reflected that, but that was our own, you know, potential bias as well, just to show those illustrations.
So another couple of questions from the other Emily. She's wondering, and maybe this is in the work you presented from Justine's study, but she's wondering if the 200 participants in your study where you did the instrumental exams, did you also screen those individuals for pre-op dysphagia, or screen them at all, I guess? And can you comment on the comparisons or how screening results might have differed from the instrumental results?
Yeah, so we didn't pre-operatively screen these patients, and that's the major limitation of this work, and with like risk factor determination. This is really just prevalence post-operatively. For the publication, we removed patients that had a history of, and for the risk factor data, so even though we recorded 200, the final N was 182, because we removed patients that had a pre-operative EAT-10 score, so that was really the only thing that we got pre-operatively. Above, I think it was a 3, and then anybody with like a known history or medical record, confirmation of history, they were removed, because we wanted to keep it, you know, even though it's not perfect, we wanted to take those out and see who didn't report dysphagia or have a history of dysphagia, develop that. But that's why we need to do a preoperative study, and that's what we have a grant under review for, to really definitively look at that. So that's part 1, I think, of Emily's question. Part 2 is, yes, this was the same data set. And yes, we do have some screening data. So that was where Justine's 3 ounce comes from. which I presented, and we're now kind of hoping to collect more, looking at things like the reflexive cough testing to look at upper airway sensory motor responses to that, as well as lingual strength and some other sort of simple bedside markers that potentially could, because we really need to get some other things for these folks since they are aspirating and we're missing a lot of them. And 37% is not a number that I'm okay with, and I don't think anybody would be. So yeah.
No. All right, a couple of other questions. So Nabil Jabor, who's a speech pathologist at our Sunnybrook Health Sciences Center, asks whether you noticed any difference in aspiration rates for the people that were scoped later in that postoperative interval, or post-extubation interval, 72 versus earlier.
Yeah, that's a great question. And that's actually something that the reviewers asked and made us rerun all the data on. And so in the publication, there's a supplemental table that actually breaks it down by defined windows of time post-extubation. And there was not any associations or relationships with time post-extubation. But the other thing I would add to that is, and in this grant we have under review, I'm very interested to see in, I think it was the 92 patients that had like the PAS score of 3. So they had sort of mild, what I would refer to as mild swallowing safety impairments, whether that sort of returns to true baseline and is safe, if you rescoped them, a week later, because we're in that kind of acute window of post-extubation. And so the grant that we have under review would actually reevaluate patients that do show that they are aspirating or have swallowing impairment at a second time point to see. So that's the next question. Well, do they get better? Like what is their spontaneous recovery? And I would suspect, and it's just no evidence, I'm just suspecting that the very milder patients, the 3s, would probably, because remember, they're also on pain medications, they're in a weakened state. So I would suspect or speculate that they may flip back into sort of normal. But whereas the aspirators or even the deep penetrators, the 5s, I think that might be a different story. And so that's what we want to look at next too.
So you alluded earlier in one of your responses to the balance between safety and efficiency. Mm-hmm. And I'm just curious, I believe when you are referring to people as an aspirator, it's sort of any one episode of aspiration across your protocol.
Correct.
And some of the work that we've done in our lab has looked at how the presence of residue on an earlier swallow increases your risk of aspirating on a subsequent swallow. And I'm wondering if you can speak to that, to what your protocol is. Do you see those relationships?
Yeah, I'm glad you asked that. We actually had a poster at DRS just this past month that showed, it was looking at sort of potential mechanisms associated with aspiration. And it revealed that in cardiothoracic surgery patients who were classified as inefficient at either site, that they had a significantly higher odds of aspiration on subsequent swallows. And the odds ratio was it was like 6 point something. It was like a 5.9 or a 6, low 6s, but they're approximately 6 times higher odds. And I did look to see, well, is there more risk if it's at the molecular site versus the piriform sinus site? I would have expected piriforms, because you may have noticed they get a lot of material flowing over the piriforms and in, which I'm kind of used to seeing the opposite in our ALS patients. It typically, comes from the other direction. But it was just about the same with both residue sort of anatomical sites. So that was significantly associated. Interestingly, vocal fold paralysis was not at all associated with aspiration, and that was because they were able to compensate. But incomplete glottic closure, which occurred in many patients, those that had normal vocal fold motion. So when we asked them to hold their breath, people that couldn't get complete glottic closure, that was significantly associated with aspiration, which I think makes sense. And so, yes, most people are focused on the safety issues, and particularly in this patient population, because of all their airway type issues. But I think that the efficiency is a really important component to the story. And we also suspect that having the Dopphoff tubes in place may be perturbating the system and maybe leading to some of that motility disorders that you saw some examples of. And so that would be something I'd be interested to look at in the future as well.
Cool. So one more question, and then we'll wrap things up. But so obviously endoscopy is a really great tool for looking at things like vocal fold closure and glottic closure and identifying vocal fold paralysis. Timing is not so easy. Timing of airway closure mechanisms is not so easy. And I think the relationship with residue is also perhaps not quite so easy on endoscopy compared to video fluoroscopy.
Mm-hmm.
So Sana Smaoui from my lab, doctoral student, has asked what you think the potential differences are between those two tools and which is the more appropriate, in your opinion, for this post-surgical population.
Yeah, that's a brilliant question. So thank you, Sana. So yes, we have a study we're about to start looking at simultaneous imaging of radiographic imaging at the same time concurrently with FEES. And I can tell you that there are differences from the pilot work we've done in the lab. Specifically, of course, everyone knows that with FEES, you can't see the oral phase or the esophageal. You can't do a screen there. But we were quite surprised at the fact that on endoscopy, it is much more sensitive to aspiration and residue if it's in the field of view, to the point where we thought we had made a mistake and given the participant like non-barium materials, but no, we had. So I think because of the potential issues with vocal fold mobility impairment, mucosal damage and injury, and in some patients, secretions, that being able to image with endoscopy, particularly in a patient that may have a very hoarse voice, although that can be confounded by the fact that they just had a tube taken out, is important, knowing the limitations of it. For the grant we have under review, we're actually proposing to do simultaneous imaging because we do want to look at timing. And so I should basically try and get the best of all worlds. That's not feasible in a real world clinical scenario. And so I think it's sort of patient specific. If you're imagining that there could be some esophageal motility issues or oral phase issues or things with timing you want to look at, then I think video fluoroscopy, you go with the strengths. However, if you suspect mucosal damage, vocal fold mobility impairment, issues with secretions, or some of these patients can't be transported down to radiology because they have different treatments going on, they have their legs up in the air. So sometimes you're just kind of constrained with that. But I think it's a good point, and we just need to realize that the two are not necessarily comparable. So if we repeated the exact same study with fluoroscopy, I would guarantee that the results would be slightly different just because of the inherent strengths and limitations of each device. And so they're not created equally, and so we shouldn't treat them that way.
It really speaks to the different information you get from the two exams. And probably my take from what you presented is that endoscopy is really an ideal first tool. And then if you are wanting more information, say you see that GERD coming back up and you want to look further down, for example, then video fluoroscopy as a second line seems to be highly appropriate.
Yeah, and I know the clinicians sometimes do that if they can. And sometimes you get an exam, obviously I showed nice ones, but sometimes you just have gunk all over the video and you need like windshield wipers, and it's very difficult to get a clear, comprehensive, visuals. And so sometimes there's the need for that as well. So yeah, it's complicated.
Yes. Well, thank you so much. I know we're at the top of the hour, so I thank the audience for participating. And it's really been a pleasure to have you, Emily.
Thank you for inviting me to you guys.
Thank you again on behalf of KITE for a wonderful talk. And thank you also, Dr. Steele, for moderating.
My pleasure.
Thank you, guys.
Have a great day, everybody.
You too. Bye-bye.